Today I'm taking the topic Amphotericin B. We'll see mechanism of action, pharmacology, and clinical uses of this drug. This is antifungal drug. In the antifungal, it's categorized as a antibiotic polyene category. Now we'll see how these drugs is act and how what is the pharmacological action, like what is the half life, duration, volume of distribution in, and how it is infused, either it is orally is given or a infusion or a IV bolus. So the first is mechanism of action. It's see basically fungus have a outer cell membrane. In the fungus cell there is a cell membrane, that is a outer cell wall, then a cell membrane will be there. In that cell membrane we can see here the different type of protein are there. So among them one protein is called that ergosterol. In that ergosterol, what will happen, this amphotericin will penetrate the cell membrane, they'll go inside, penetrate the cell wall, and they'll go inside, and it will bind to this ergosterol. That is in a normal body, esterol, yeah, cholesterol will be there. So what cholesterol will do, it will strengthen the outer layer of the cell wall. So same as like normal cell, normal human cell, in a fungus also, ergosterol will strength and fluidity to this outer cell wall. So this amphotericin will go and binds to this portion and make a pore. Once the pore is made, then the whatever the fluid is there in the cytosol, then that will be efflux out, means it will go out from the cell and the cell will die. So this is the main mechanism of the amphotericin B. So now the next is this, we can see here, this is the visual representation. Healthy fungal, now drug binds and the pore formation in the cell death. So it is not only acts on the ergosterol, it will also act very less amount, but it will also act to the cholesterol also, that is only present in the human cell. So because of binding to the cholesterol, it shows some the toxicity also. And there will be the leakage of ions, that is a potassium, magnesium, calcium, and other molecules. So pharmacological overview will see the spectrum. So basically before going to the spectrum, there are two type of amphotericin B. One is conventional and one is liposomal. So before it was like in starting it was a conventional drug. That time it will go, and a very less amount of very less concentration of drug was causing the toxicity. So for that they will, and one more thing was that outer cover was that amphotericin B, there was a very outer cover was not there, so that the degradation of drug was also happening. So for protecting the drug content, this lipid outer membrane they formed after that, and they brought the drug into the market so that the lipid content will easily penetrate the cell wall of the fungus and go and bind to the respective sites. So spectrum will see the it will affect against the yeast, mold, demographic fungi including the Candida, Aspergillus, and Cryptococcus species. It will also help to treat the blastomycosis, candidiasis, cryptococcus, histoplasmosis, and basically it is given for the CNS penetrated infection. So the dose is for the conventional, the dose is 0.5 to 1.3, and it should not exceed the 1.3. basically it should not exceed the 1 mg per kg per day, but sometimes it's given for the CNS infection, it will go up to the 1.3. Now, protein binding is a highly protein bounded drug that is greater than 90%, results in the extensive tissue distribution. The drug is lipophilic in nature, allow the penetration into various body compartments, including the CSF, pleural fluid, and a peritoneal fluid. The half-life is actually the half-life of this drug is 7 to 15 hours, but extended elimination half-life, that is the terminal half-life, once the drug is given and after till the 15 days the drug concentration will be there in the body. So the extended elimination half-life of approximately 15 days with the conventional formulation, allowing for the sustained antifungal activity but also prolonged exposure to the potential toxicities. Now administration, we'll see, must of yeah must be administered intravenously due to the poor oral viability. So, and lipid formulation, that is a liposomal and a lipid complex, significantly reduce the nephrotoxicity while improving overall tolerability and the patient outcome. So as I said before, when this drug was invented, that time it was a conventional form. Later on, for better tolerability and stability, they made a drug such a way that outer cover of the drug was lipid soluble. Now next is dosing. So for the conventional formulation, that is 0.3 to 1.5 mg per kg per day, administered as an IV infusion. Dosing varies based on the indication, severity, and the patient tolerance. Test dose of 1 mg over 20 to 30 minutes is typically given initially to assess for the acute hypersensitivity reaction. So next one is lipid formulation, that is a liposomal amphotericin B, which is given as a 3 to 6 mg per kg per day IV, depend upon the clinical indication. So for blastomycosis, candidiasis, cryptococcus, and histoplasmosis, and aspergillosis, they used to give 3 mg per kg per day. But when it comes for the CNS infection, they will go with the higher dose, that is a 5 mg per kg or 6 mg per kg per day. Now pediatric dose, generally minor adult regimen on a mg per kg basis, because of the smaller dose we have to give. And the neonates and infant require the particularly careful monitoring due to immature renal function. So amphotericin have a known this interaction with the other nephrotoxic drugs, that is like such as aminoglycosides. Tests done are essential in the pediatric population to prevent the severe infusion reaction. So lipid formulation allow for the higher therapeutic dose with significant reduced nephrotoxicity, making them preferred for prolonged therapy or in the patient with a baseline renal impairment. So there is no any dosage adjustment in the renal impairment, as this drug itself doesn't cause any the renal impairment, but we should check time to time that renal function, because including this drug, any other drugs might be given which is causing the nephrotoxicity, such as aminoglycoside, one of the common drugs. The cumulative dose limited, that is monitor the cumulative dose carefully throughout the treatment. Nephrotoxicity risk increase substantially with the total dose exceed 5 gram. This is the main thing. And for the conventional formulation, avoid daily dose greater than 1.5 mg per kg to prevent the potential fatal cardiopulmonary event. For the special population, elderly patients use extreme caution due to the age-related decline in the renal function and increased susceptibility to electrolyte disturbance. As we know, as the age grow up, the electrolyte imbalance will be there in the higher adult, in the elderly patient, sorry, and so that there should be a continuous monitoring of the electrolyte and the renal function test. So pregnancy category B, Use only if clearly needed and potential benefit justified risk. Breastfeeding, limited data available, generally not recommended during the lactation. Hepatic impairment, no specific dose adjustment required, but monitor liver function closely, because around 60 to 70% of the drug is metabolized by the liver. And even the this renal function is measured just because of the primary excretion is the urine, and secondary is the bile. So both the hepatic and the renal function should be measured. Now adverse drug reaction. So hypokalemia is common because of the potassium wasting due to renal tubular damage. That is a 31 to 51% of patient is facing this problem. Then anemia, decreasing the erythropoietin production, then the hypomagnesemia, and then a nephrotoxicity. So it is this amphotericin B is commonly given as an infusion. So infusion related reaction typically occur 1 to 3 hours after initiation. Basically infusion is just the dose of the drug, that is like 3 mg to 5 mg infused over the 2 to 6 hours, that is the infusion period. So this infusion related reaction will also occur after probably 2 hours. So it includes the fever, rigors, chills, headache, nausea, and vomiting. So these reaction can be subsided by the use of antipyretic, antihistamine, that is a diphenhydramine, and in severe case corticosteroid, that is hydrocortisone. And for the rigors, it's a use mepridine, that is a opioid analgesic. In contraindication, there are absolute contraindication, known hypersensitivity to amphotericin B or any formulation component, use in a non-life threatening fungal infection in an immunocompetent patient. And a relative contraindication and warning: if it is there a pre-existing kidney disease or elevated baseline of a creatinine, it should not be given. And even if the electrolyte is imbalanced, that is if it is hypokalemia, hypomagnesemia, then this drug is contraindicated. And if it is cardiac conditions such as arrhythmia, conduction abnormalities, as we know, this hypokalemia and hypomagnesemia both can cause the cardiac complication, arrhythmia. So this drug should be avoided in this cardiac condition also. And if it is concurrent use of other nephrotoxic medication, so this should be avoided. And lactation is not recommended, and data is also not sufficient. So monitoring parameter, we should see the renal function, that is serum creatinine, blood urea nitrogen, urine output daily during the treatment, assess the creatinine clearance. Basically in a renal function, drug is determined basis on the creatinine clearance. So they will check mostly the creatinine. And the next is electrolyte, that is normal. They will check potassium, magnesium, calcium, and the sodium level at least twice weekly. That is the recommended from the recommended in the monogram. Then hepatic function, that is a monitored liver function test, that is AST, ALT, alkaline phosphate, and bilirubin weekly, because the excretion is from the biliary excretion is also there, so that if any abnormality is there, then the drug accumulation might be there, might be possible. That's why the hepatic function is measured. Then a hematological monitoring, that is CBC, with a differential at a baseline and weekly. Monitor for anemia, thrombocytopenia, and leukopenia. Assess for the hemolysis in the patient with a prolonged therapy. The vital signs and infusion sites, as we see the monitor temperature, blood pressure, heart rate, and respiratory rate continuously during infusion, and for 4 hours post infusion. That was for hypersensitivity reaction of the infusion. And also see the IV site frequently for the sign of thrombolevitis, that is a pain, redness, swelling, and the vein hardened. So now the how the drug is administration, how the drug is administered. So there is a guideline, that is a test dose. The administered 1 mg over 20 to 30 minutes. Observe the patient closely for the acute reaction. After, if it is if any reaction is not there, then again after post infusion you should monitor the vital sign and assess for the delayed reaction for at least 2 to 4 hours the completion of this infusion. So therapeutic infusion, that is infused slowly over 2 to 6 hours thoroughly, dedicated IV line, and never administration as a rapid bolus. So key drug interaction is nephrotoxic drug. It will in nephrotoxic drug. So this drug should not be given along with the cyclosporin, tacrolimus, aminoglycoside, cisplatin, and NSAID to avoid to induce the nephrotoxicity. And even this amphotericin should not be given concurrently with corticosteroid that may exacerbate the hypokalemia. So for this, if any corticosteroid drug is going on with amphotericin B, then monitor the electrolyte. Digitalis glycosides. Hypokalemia increase the risk of a digitalis toxicity. Then other is antineoplastic agent, enhance the nephrotoxicity and bone marrow suppression. So the combination is avoided. Then the flucytosine, that is a flucytosine is also antifungal drug. If amphotericin B and the flucytosine is given together, it will give the synergistic effect, which will also potentiate to increase the toxicity. That's it, man. Thank you.